Hello everyone. Today in this video, I am going to tell you the details of CNS examination in the newborn baby and neonatal reflexes. It is a part of CNS examination. So in the CNS examination in the newborn, first we have to assess the higher mental function, then cranial nerve examination, then motor system, sensory system and neonatal reflexes. Then in last, skull and spine should be examined. So in higher mental function, in newborn baby, first we should assess the state of the baby, then level of consciousness, then facial expressions, then orientation and behavior, then nature of cry, then breathing and feeding pattern, and habituation. So in the state of baby, here in this video you can see baby is fully active and crying and eyes are closed and respiration is regular. So this is the state 5. So from state 1 to state 5, when baby is in quite deep sleep, label as a state 1, then baby go into the REM sleep, it is state 2, then quiet wakefulness is there, state 3, then active wakefulness, state 4, then baby become fully active and crying in state 5. So in the state 1, eyes are closed, regular respiration, no movements. In REM sleep, state 2, eyes closed, but respiration is irregular. No gross movements are there. Quiet wakefulness, state 3, when eyes open and regular respiration, but no gross movement. Active wakefulness, state 4, similar to the state 3, eyes open and regular respiration, but there are gross movement of the limbs present, but no crying is there. In fully active and crying state 5, with this baby is crying also. So here in this video, baby is in the state 5. Then assess the level of consciousness. Baby is alert, active as in this video, or having the irritability, lethargy, or baby is drowsy or stupor or comatose. We label the normal consciousness or normal alertness when the baby responds normally to the arousal and having the normal movements of the limbs and face. We label the irritability when neonate cannot be soothed or cannot be consolable and having the irritable behavior and agitated cries with the minimal stimulation. That means baby is irritable. We label the lethargic neonate whenever neonate is unable to maintain the alert state and but it is arousable but not having the alertness. Then we label the lethargy. Drowsiness and light coma when the baby is only arousable by sound, verbal stimuli, otherwise baby is sleepy. Stupor or moderate coma when baby is having the absent arousal and motor response by the verbal stimuli or sound, only arousable by the painful stimuli. Deep stupor or coma or unconsciousness when baby cannot be aroused by the painful stimuli, motor response are absent. So these are the level of consciousness. Then observe the facial expression of the newborn baby, either bland or alert or fussing or crying or frowning can be there. Then we have to assess the behavior of the newborn baby. We can assess by the Brazelton Neonatal Behavior Assessment Scale. In this, we are assessing both cortical and subcortical function. There are total 47 items we have to assess. 27 behavioral and 20 we have to elicit the response. So in the behavioral, we have to see this response to the various stimuli. Example to the motor activity, change in the skin color, and we have to elicit the various response. Example, grasp reflex, rooting, sucking, moro reflex, and glandular tape. And we have to also see the patient's orientation to the visual, auditory. So all are included in the Brazelton Neonatal Behavior Assessment Scale. And for the behavioral item, we have to give the score on the 9-point scale, and in the elicited response, we have to give the score on the 3-point scale. Then we should do the assessment of the neonatal cry quality, type, duration, and intensity of the cry. So the loud and lusty cry is the normal cry for the full-term neonate. Whenever baby is depressed and having any illness, then cry will be weak. High pitched cry is especially seen in the neonatal condition, example in meningitis. Whenever there is a prolonged or excessive cry, means baby is crying for more than 3 hours, not consolable with any measures, and you had tried for the feeding and you have changed the diaper, still the baby is not consolable. It suggests that baby is having the irritability, and there are various causes of irritability in the newborn baby. Then we have to assess the breathing and the feeding pattern of the baby. In breathing, we have to check the rate, rhythm, depth, and any sign of respiratory distress. All will be included in the breathing pattern of the neonate. And in feeding pattern, any abnormal feeding pattern is there. Example, poor sucking, refusal to feed should be mentioned here. Then we have to test the habituation. Normally, newborn is having the capacity to habituate whenever we are giving the repeated stimuli. Example, visual, auditory, or any painful stimuli. Then baby can adapt adequately to the stimulus. And to test and to perform the test for the habituation, we can perform the Moro reflex, or we can perform the glabellar tape. So here in this video you can see I am performing repeatedly Moro reflex. And shutdown of the body movement, or we can say decrease response seen after 3 to 4 stimuli. So if you are performing the glabellar tape, then diminution in the blink response occur after 3 to 4 stimuli in the normal healthy full-term baby. If it is persisting, that means baby is having the abnormal neurological function. Then we should assess the cranial nerve examination. So first, olfactory nerve for the smell. It is rarely tested in the newborn baby, and we can test this nerve by the glove or mint. Normal response in the newborn baby will be the change in the behavior. Example, grimacing, startle response can be there in more than 32 weeks of gestation age baby. In less than 32 weeks of gestation age, no response will be present. Now, second, optic nerve for the vision. It can be tested by shining the torch light in the peripheral visual field. In more than 28 weeks of gestation age baby, baby will blink in response to the light, while in the more than 32 weeks, baby will turn the head toward the diffuse light. We have to move the bright object side by side. We can choose the red color ball or any other red color object, and distance between the eyes of the newborn and the object at least 1 feet far from the neonate's eye, because visual acuity in the term newborn is 6 by 45. So we have to keep this distance. The normal response in more than 34 weeks of gestation age baby will follow the moving object red ball and able to fix. Here you can see this is the red object 1 feet far from the newborn's eye, and we have to see newborn is moving the head toward the object or not to assess for the vision. Then we have to check the pupillary light reflex. For this we have to shine the torch light and from the peripheral visual field, and we have to see the pupillary constriction in response to the light in both the eyes. So pupillary light reflex absent in less than 30 weeks of gestation age baby and completely develop in more than 35 weeks. We consider the direct pupillary light reflex when pupil constrict in response to the light in same eye. and pupil constrict in the opposite eye is labeled as a indirect pupillary light reflex. Here in this video you can see how to perform the pupillary light reflex and also check the response to the light. Baby is blinking in response to the light and also turning the head toward the diffuse light. And for the pupillary light reflex, for the direct and indirect both, we have to shine the torch light from the lateral position towards the pupil, and we have to see the constriction of the pupil on the same side of eye, mentioned as a direct pupillary light reflex, and in the opposite eye, indirect pupillary light reflex. So, abnormal response to the pupillary light reflex can be seen whenever there is a lesion in either in the afferent or efferent pathway. So, afferent of pupillary light reflex is second cranial nerve and efferent is third cranial nerve. So, an unresponsive direct and indirect both pupillary light reflex from light shined in the eye on the side of second cranial nerve lesion. Example, if the baby is having the left-sided optic nerve lesion, then when you will shine the light in the left eye, there will be no pupillary constriction occur in both the eyes. And when you will shine the light in unaffected eye, example, when the left optic nerve is damaged, you are shining the light in the right eye, then both the pupil will constrict, both direct and indirect will be present. When efferent pupillary defect is there, when the lesion in the third cranial nerve, then unresponsive ipsilateral pupillary constriction on the affected side when the light is shined in either eye. So if left third is affected, then uh, left-sided third cranial nerve if damaged, then in left eye there will be no direct, no indirect pupillary response occur. So absent pupillary light reflex in on the affected side will be present in third cranial nerve. If pupil is dilated and fixed when you are shining the light, that means baby is having either optic atrophy or retinal detachment. Then we have to perform the fundal examination. In fundus examination, normal finding will be optic disc is pale whitish gray in color. Red reflex by +10 diopter lens of the ophthalmoscope at 10-inch distance. Present of red reflex is normal. Whenever absent or abnormal red reflex, we can say example in congenital cataract, retinal abnormality, retinoblastoma, strabismus or refractory error is there. Then we have to test the oculomotor nerve. We can again check the pupillary light response for the third nerve because third is the efferent for the pupillary light response, and details I have already explained in the previous slides. And also we have to check the spontaneous and symmetrical eye movements of the both the eyes. For the fourth cranial nerve, trochlear nerve, again we have to observe the eye movement, symmetrical eye movement. As we know, SO4, superior oblique, is supplied by the fourth cranial nerve, trochlear nerve. For the sixth cranial nerve, abducens nerve, we have to see the spontaneous eye movement because abducens nerve supply the lateral rectus, LR6, and we have to perform the vestibular ocular reflex, Dole's eye maneuver. In this, we have to gently rotate the head to the side and we have to assess the direction of eye deviation. Normal response in the newborn baby, eye deviate away from the direction of rotation. If you are turning the head toward the right, eye will be deviated toward the left. Dole's eye maneuver valid in more than 25 weeks of gestation age, always present in first 10 days of life and disappear when fixation develops. Here in this video you can see head is turned toward the left side and eyes are deviated toward the right side. This is the Dole's eye maneuver. For the trigeminal nerve, we can perform the glabellar tape in the newborn baby. We have to repeatedly tape the newborn's head between the eyebrows and nasion here, and we should perform from the above and behind the patient to remove the visual stimuli. We have to remember that whenever we are performing the glabellar tape, we should stand uh, on the head side. Prompt closure of the both eyes in response to the tape occur. In normal newborn baby, blinking response disappear after 3 to 4 taps, as I have explained in the habituation also. Then we have to perform the corneal blink reflex. We have to touch the cornea lightly with the piece of cotton wool. Normal response in healthy baby, it will stimulate and eyes will be closed. And afferent for the corneal blink response, trigeminal sensory nerve, and efferent is facial motor nerve, which innervate the orbicularis oculi muscle. See in this video how to perform the corneal blink reflex. For the trigeminal, we have to check the facial sensation also. We can lightly touch the face for all three subdivision of the trigeminal nerve. And rooting reflex we have to elicit. Here in this image you can see, and sucking reflex also we have to check. For facial nerve, we have to observe the facial symmetry when the baby is at rest and when baby is crying. So baby is closing both the eyes normally, forehead wrinkling is there, nasolabial folds are bilaterally symmetrical. That means seventh cranial nerve is normal. And also glabellar tape and rooting reflex as the facial nerve is efferent for the glabellar tape. See in this video how to perform the glabellar tape. Then for the vestibulocochlear nerve, we have to assess the hearing. And for the assessment of hearing, we have to stand behind the baby and we have to clap. This will create the 60 decibel sound. More than 28 weeks of gestation age baby will show the response by blinking the eyes or a startled response or sudden change in the activity, or some body movements can be there in response to the sound. We can check the pharyngeal gag reflex whenever we are performing the suction, and we have to observe the when baby is taking the breastfeeding. So we can check the sucking, swallowing and breathing coordination in more than 34 weeks of gestation age baby by observing the when baby is taking the feed. Then for the spinal nerve, 11th cranial nerve, sternocleidomastoid and trapezius muscle, we have to turn the gently head side to side, and we have to also compare the shoulder height of the normal newborn baby. For the hypoglossal nerve, tongue function, tongue symmetry, when the baby is taking the feed, we can observe the tongue movements and tongue symmetry and tongue fasciculations. Today in this video, I have covered the higher mental function and the cranial nerve examination in the newborn baby. The rest of the part I will cover in next video. Thank you so much.